Hello and welcome. A few notes as we begin. Our webinars are not intended to replace medical advice. Instead, it's by those who are living with neuroendocrine cancer for those living with neuroendocrine cancer. We want to help other neuroendocrine patients navigate this complex journey of neuroendocrine by sharing our stories and pathways to the patient we are today. We will recap the topics from the previous webinar on the 20th of September that is now available on the NC UK website. Then discuss some key areas, emotional support, where to go, top tips and terms used in consultations. I'd like to thank NC UK for allowing us to do another webinar this evening, and to my team for the great help they've given me throughout this. We're going to do tonight as a bit more of an open conversation as opposed to a scripted team. But now, first of all, let's meet the amazing team behind it. So I'm Chrissie. I've had neuroendocrine cancer for 28 years. Primary was in my pancreas, multiple surgeries, multiple recurrences, including a liver transplant in 2006. And currently no evidence of disease under the Royal Free.
Hi, I'm Kath. I was diagnosed in June 2015, so it's 10 years for me this year. I've got neuroendocrine primary in the small bowel with spread to liver, lymphs and peritoneal wall. I'm classed as inoperable, so no surgery for me, but I have had PRRT, which I had in 2018, 2019, and thankfully that's still doing the job that we hoped it would do.
Sadly, Polly, our carer ambassador, is unable to be here this evening, but Polly is a carer to Mike, who was diagnosed in 2014 with primary of the small bowel, mets to the liver, more recently his heart and various lymph nodes, and he's currently undergoing some chemotherapy. Also tonight, sadly, Carolyn is unable to be with us due to ill health, and she was diagnosed in 2005, primary small bowel with mets to liver, bones, including spine, abdomen, lymph nodes. She's classed as inoperable currently.
Hi, my name's John. My primary small bowel with mass to the liver, diagnosed in 2009, age 33. Lanreotide injections 120 3 weekly. I've had octreotide injections daily, which are both self-administered. Embolization of the liver in 2010. Nuclear treatment Y90 in 2012, and small bowel resection in December 2022. And on the 5th of August 2025, I had a liver transplant through the NETS pilot scheme. Primary care is at the Royal Free in London, with split care with my local hospital in Bath.
So in the first webinar, we covered topics of neuroendocrine cancer, diagnosis investigations, diagnosis confirmed, treatments, follow-up plan, net centres of excellence, family and friends, the carer's experience, navigating the future with misconstrued statements to finish. All of this is available to watch, like I say, on the NC UK website, nicely pinpointed on the screen there, where to go and find it under help and support, and search for webinars.
Now, before we continue, we would like to play a short video from Lisa, a fellow patient ambassador living with a lung net diagnosis. Lisa was invited to share her story as part of the Will Norman Nurse Education Programme to raise awareness and understanding of neuroendocrine cancer, a collaboration between Neuroendocrine Cancer UK, Australia and New Zealand. Will Norman was a son, brother, husband, father and teacher who emigrated from the UK to Australia to work and raise a family. He died in 2021 at the age of 41. The Nurse Education Programme named after him is supported by a legacy donation from Will's family.
Hello everyone, my name is Lisa Webb. I am a 51-year-old mother of two who is living currently in Leeds in the UK. I'm originally from Ireland, and my journey with NETS started in Ireland, I suppose. So my diagnosis is that I have a lung net, an atypical lung net, which there's a long history with it, really. So I think the first symptom that I was 35 and had become quite breathless and noticed that I had a cough that wouldn't go away. And I went to see my doctor, but I'd been diagnosed with asthma at 19, and it was felt that this was a recurrence of asthma, really. And I was put on an asthma plan that didn't do anything at all for the symptoms. And that started a process of going back and forward to doctors on a regular basis, trying to get to the bottom of what was going on. Unfortunately, I suppose my experience with the medical profession at that time wasn't great, and I'm happy to say that in later years it did get a lot better. But in those early days, I felt like I just wasn't heard. I wasn't listened to, and a lot of times I think the onus was put back on me in terms of not following asthma plans accordingly. And anyone who knows me knows I'm a stickler for rules. So when I'm given a plan, I will stick to it quite rigidly. So going back and forward to the GP for a while, I was put in touch with the asthma nurses, and there was a variation really of responses from asthma nurses at that time. There's quite a high turnover in our surgery, so I never really got to build a relationship with one particular nurse, which I often look back and think was part of the missing piece, really. So I was seeing different nurses at different times, being put on increasingly heavier inhalers, and nothing was working. The other thing was that I was really quite fit and healthy at that time outside of these symptoms. So I was running at that point. I was in the gym every morning, quite fit and healthy, looked after myself, had a great diet, and felt really good outside of this. So when I was constantly being told it's just asthma, I suppose I just learned to live with it. And going back and forward to be told you need to do this better, you need to, perfect your technique with your inhalers. I really did feel that it was something that I was doing wrong. And I think I just internalized that and moved on with my life and continued to just try to live with these symptoms. So fast forward a few years coming up to the COVID pandemic in 2020, things were getting a lot worse. And I started to have this real issue about lying on my left side, and I couldn't catch my breath at all. So it felt like there was a blockage there, and I went back to the doctors and was saying, I can't lie on my left side, I can't breathe, this is really quite strange. And the response I got from every medical profession was a head scratch, just not quite sure what this is about. It doesn't seem to make sense and doesn't fit with the asthma. But nothing really further was done. There was no follow-up. I do remember one locum doctor one time, she'd give me a good sounding out in my chest, and she said, you don't have asthma, your airways are clear. But she sent me for a heart scan instead, because I also have a heart murmur, so it was quite loud, and sent her on the wrong path, I think, in terms of she knew something needed to be looked at, but unfortunately we went on the wrong path. So when the heart scan came back clear, again, it was a case of, well, we don't know, basically, stick with your asthma plan. So I moved to England. This all occurred back in Ireland. I moved to England for work in 2021. And the first thing I did was register with the GP and make an appointment to see the asthma nurse, because I was struggling now. It was COVID. I was really anxious about being able to breathe in the middle of this pandemic. And the asthma nurse here in England, she was just fantastic. She really listened when I was saying something doesn't feel right, something's getting worse. I do these things, I follow these plans, nothing's helping. And she put me on another asthma plan, but monitored it quite closely. And within 6 months of back and forward, she said, I'm not happy, I'm going to send you for an x-ray. So she sent me for an x-ray, which was quickly followed up by a CT scan, and then the diagnosis came quite out of the blue then in December 2021. And I do always remember going into the hospital for the diagnosis. Cancer was not on my radar. You know, I'd suffered with these symptoms for so long. I thought if it was cancer, I'd be dead by now. You know, my only understanding of cancer was that it was quite deadly and I wouldn't survive that length of time with cancer in my lung. So I went to the appointment on my own. I didn't. My husband had wanted to come with me. I told him not to bother. I thought I was going to go to be told I had COPD, which runs in my family. But so the diagnosis was a complete shock, absolutely a complete shock. And again, it was the nurse. The doctor gave me the diagnosis. I was in total shock and really had a bit of a meltdown. And it was the nurse who came in and took me into a side room and spent some time with me, reassuring me. It was all a blur at that stage, but I do remember quite clearly some of the things that she said to me. Firstly, she held my hand, which really helped center me, just brought me right back into the room. And she just kept rubbing my hand and saying to me, "We've caught it early, don't worry." And I remember thinking, I've had these symptoms for years, this is not early. But she was saying it's early enough, we can treat it, things are going to be okay, you know. So she was very good, helping to support me there. Then there were a fantastic set of lung specialist nurses who tried to support me in the best way they could, but they had limited knowledge, I think, of neuroendocrine tumours. You know, their speciality was lung, and this was a neuroendocrine tumour, so there was quite a difference in what they could do and how they could support me. So unfortunately, I had to lose a complete lung because of the position of the tumour. I had to go in for the pneumonectomy. It was done during COVID. I had to go into hospital on my own, spend 8 days in hospital without visitors. You know, a really trying time. And again, I remember one or two nurses who were just fantastic and being, you know, human, really, being able to take time in the middle of a very busy shift to listen to you and, you know, just support me really through a very, very difficult time. So in terms of afterwards then, the recovery period, I was told at diagnosis it was a typical lung net. It turned out then in the histopathology that it was an atypical lung net. I had sort of really researched neuroendocrine cancer during that time, and I became aware that, you know, as a result of it being atypical and that I had lymph node involvement, that this was a significantly different situation from a typical net. But again, I found that in the medical profession that wasn't really well understood, and I was offered a treatment plan that was no different from the typical lung net treatment plan. So I had to advocate for myself. I had to work quite hard to find a specialist, a neuroendocrine specialist in Manchester, which is quite a distance from where I live in Leeds. But I travelled there to the Christie in Manchester, and Professor Mansour agreed to take me on as a patient. And from that moment, everything has just fallen into place because I've got people who really understand this disease and who can reassure me in the darkest of moments when I'm panicking about every little symptom, that, you know, things are okay, that they know this disease and they can understand it. So I think really in terms of my journey with the medical profession throughout this really difficult period, it's been hit and miss. I often feel quite aggrieved actually about the early years and how I wasn't listened to. And I often wonder if I'd been listened to earlier before the tumour grew in any great size. Could I have saved my lung? You know, would something have happened where I wouldn't have had to lose a lung, because it's quite an impactful thing in life. So I don't know is the answer to that. I'm not quite sure, but the feelings of being unheard, unlistened to, this hierarchical structure that can get going within the medical profession sometimes, where you feel you can't question, you can't push. It was all very difficult and led to a situation where I was left for very many years with symptoms that I shouldn't have been left with. On the flip side of that, the the good medical professionals I've come across who take time and listen and really understand, not in terms of symptoms that fit in a box, but how this disease is hitting me personally, how I'm experiencing it, what my symptoms are. You know, back in the day, I was a 45-year-old woman who was running, was in the gym and looking after myself, and was quite easily dismissed then in terms of, you know, you're fine, you're fit, you're healthy. But if someone had taken time to listen to, I can't breathe on my left side, this is not normal, and just sent me for an x-ray, you know, things could have been so much different. So I suppose my key note really to any nurses that come into contact with patients that don't fit quite neatly in a box, please listen, you know, just please listen to their experience, what they're telling you about how their body feels. Because what I've come to learn is that I'm the expert of my body, I'm the expert of what goes on inside me, and I can communicate that quite clearly. The issue is whether people are willing to listen or not. But I'm really grateful to the medical profession that have got me where I am. You know, I'm still alive and kicking. I'm going to be a grandmother next year. I'm delighted to get to the point in life where I can really sit back, look at a traumatic experience and say, I'm okay. You know, that there are people that are looking after me. And I wish that for every NET patient really that comes into contact with medical professionals. So please listen, please take on board the patient's experience and ask questions when things don't look right. Thank you.
So yeah, so an amazing video from Lisa there, explaining the fight and battle of getting the right patient care and getting nurses and medical staff to listen to you. So we will now go on to talk a bit more in detail about emotional support for the patient and the carer. And obviously NC UK run their support groups, either face-to-face or online or a bit of hybrid. And they're often believed to be something they're not. These groups they're not for everybody. And that's okay. You can interact as much as you want, or not at all if you just want to sit and listen and be with somebody who has the same disease as you. But if and when you are comfortable, then you can talk and join in. There's no judgment in these groups. It's just a group of people in the same, but different in most cases, situation you are. And all happy and open to listen to anything you have to say. So I'm going to go to Jon and Kath to discuss running a support group and face-to-face and their experiencing and what it brings to them as a patient and an ambassador, and what it brings to their group of people that they share this with. Jon, do you want to go first?
Yeah, so I think the single most important thing with the support group really is the place where you can actually meet somebody with the same or a very similar diagnosis to you, because we're all aware of this interesting or rare, however people want to misdiagnose us. And if you go along to a normal oncology department, you're very unlikely to meet many people with neuroendocrine cancer. So what we feel is by coming to one of these groups, you are much more likely to meet somebody with exactly what you've got or very, very similar, even though there's a huge umbrella of neuroendocrine cancer. And that has been, you know, very, very important to me. So you get to meet people very similar to yourself, and it doesn't make you feel so different really, or lost, which I think is really important when you're in your early days of diagnosis. I'm going to be honest, like Chrissie just said, I went along in the early days thinking this isn't going to be for me, I'm not sure about this, and I was completely wrong. I think it's a really unique situation, and you get to meet some amazing people. It's not a medical, it's just like this really. We're just sort of trying to help each other along through, give each other a bit of advice, just support, really. It's very relaxed. There's often no agenda, and it's just a nice place to really meet people, really. People come and go. Not everybody comes. We run ours every 8 weeks, 2 months in Bristol, and not everybody comes every time. They just sort of come and go as they feel they need to, and it's just a good place we can talk about our personal problems, really. I know you run yours slightly different than us, Kath. Yeah, so you probably got a few different words you want to say.
Yeah. I run our local natter is also run 2 monthly like John's, but I help to facilitate a hybrid natter, which means as well as having people coming into the meeting face to face, we also run a Zoom meeting alongside of it. So as if people can't make it in person, they can still join in, and it works very well for us, especially as we've got a few older patients, especially who physically can't attend now like they used to, whether it's to do with actually just the problem of getting there or not having anybody to bring them. But we have a mixture of patients, family and friends, and it is a friendly, safe environment. We never know how many will turn up. We can have more on the screen than we've got in the room sometimes, but it doesn't affect the meeting. It's everybody supports everybody, no matter what the problem is, and we tend to just go with the flow. Luckily for us, we have Nikki at the meetings as well, which is great when it comes to the medical side of things and just the general chit chat. I can remember my first meeting 10 years ago like it was yesterday. It was I was very nervous about it, but as soon as I sat down, I knew I was in the right place for me. I was with people who knew what it was like to be like me. It was as though the word they use now, I'd found my tribe. So if you're thinking about it and you're nervous about it, if you've got a local natter that you can get to, I thoroughly recommend it. If you don't like it, you don't have to go again if it's not your thing. But it's definitely worth tipping your toe in the water and giving it a try. And we have got some quotes here from people who've attended support groups. It can be a great place for comfort and support. Be careful that the responses are not too much and irrelevant to your question. It's you need to be aware that sometimes you might hear things that you don't want to hear, but that's because everybody is allowed to be open about how they feel. Nothing's off the table. But quite often, we have a bit of a laugh, and there's friends we've made for life. There's people at the meeting I go to that have been going there longer than I have, and they have become lifelong friends.
I've also got some quotes to refer to. I thought support groups were all tears and knitting, so pleased I found out the truth. And it was listening to the recent self-advocacy podcast that made me try. The tips I've learned tonight: who knew you probably qualify for pre-prescriptions? Who knew you could order a hidden disability lanyard? Who knew you could have a disabled rail card? And who knew health and welfare power of attorney is a good idea? All discussed at my new patient support group. What a friendly and knowledgeable group. Thank you. And all throughout my short disease journey, I felt I'm a bit of a nuisance, that I'm asking too many questions, that I'm worrying too much, and I've been repeatedly told that I should go home and try and think and do something else. This just exasperates any anxiety and depressive thoughts about what is not being shared. And for me, it beggars belief that most of the cancer professionals that I've dealt with don't see, or worse in some cases, simply don't choose to ignore my clear need for full disclosure. even with psychology input. It was therefore quite enlightening and reassuring to listen to an NC UK podcast highlighting patient quests to understand the detail and nuances of the disease through both educating themselves and also by developing a two-way relationship with medical teams. All of a sudden, I don't feel such a freak of fighting for the best chances. And attending my first support group after this was a revelation. What took me so long? The support issue avoidance is definitely more of a bloke thing. Most of us manage all our lives accepting poor communication, avoiding reaching out for help, keeping thoughts inside, and God forbid showing any emotions. I finally gave in, and now I look forward to our meetings. But following a cancer diagnosis where self-agency is often limited, finding support is one of the practical things we can do for ourselves, and which has proven efficacy for overall well-being. I would say try a support group. It helps. Stop dithering and give it a try.
And also, there is a friends and family support group online as well for your friends and family, which gives them the type of support that they need, and it gives them an outlet as well.
Yeah, Polly, who has a lot to do with the friends and family online support group, has sent some notes this evening. She says that she's covered a lot of this in the first webinar, but in terms of attendees, core of regular people and a new people every time, even a neighbour of someone wanting to know more about NETs and how she could provide support to her friend neighbour. Sometimes adult children of NET patients don't want to ask their parent to have to explain everything to them, and they're able to come and ask questions, where to find information and get reassurance that how they are feeling is okay. I think from Polly's point of view, it's great for the carers to be able to, talk openly and ask questions that maybe the patient doesn't want to hear sometimes himself or know the answer to, because it's upsetting to them. But the carer needs to know the ins and outs of it as well, and the understanding of it. So going to the support group where they can talk openly and be heard as the carer, going through it in a different perspective to the patient, it probably finds that a brilliant support for her. And I know that for a fact from what she's told me in the past. Site-specific online support groups. I'm not a great familiar person with those. I've not attended one. But I think Kath, you said you had. So I'm just going to throw you out there.
I've attended the small bowel one, which I found very very interesting, and I think the site specific groups especially useful for newer patients, because there's a lot that you can relate to. So rather than just having like in the face-to-face natters, you can talk with people more specifically about your own primary and how it affects you and how similar or dissimilar you are to others. They're definitely worth attending, definitely. And I think John, have you been to one as well?
Yeah, I've been to a small bowel one. Yeah, definitely. I agree with everything you said, especially something like small bowel where you've got sort of your toilet issues, and it's a very open place. You can sort of discuss anything.
Yeah.
And our normal natural groups you can, but when it's something sort of really personal like that, it's a really good place. And you just pick up so many little hints and tips off of people. Even after I've been taking my bowel drugs now for 5 years probably, I recently just learned something that just by switching a couple of my drugs around, taking one before the other, is just made a massive difference just to me personally, and that was after many years. So yeah, I highly recommend them. They're really, really good.
And even though I've said this before, no matter what, whether you're in a meeting or an appointment or anything, if you have a question, there is no daft question if the answer is important to you. So don't be afraid to ask.
And obviously there's many Facebook forums that we have as neuroendocrine cancer. Obviously, there's a patient-only one, patients, friends and family support groups, many places that give you excellent advice. The only thing I would say is sometimes be wary of some of the answers from my perspective, because they kind of go off piste a little bit and don't necessarily answer your question to what you're asking, and could become confusing and more distressing for you if you are absorbing everything that you're given. But they're an excellent place for comfort, for sure, and information. They give amazing information, the facts and figures that you get out of those, and the support you get with people that you've never met before. It is just, second to none. The community of neuroendocrine cancer UK on all of the Facebook pages is brilliant. I don't know if Kath or Jon, you've got anything further to say, but I think that covers pretty much.
Yeah, we've got our own little WhatsApp group as well, which is very useful because it means you've still got contact with the group. You're not waiting for your next meeting. I mean, a lot of the times it's just a general chit chat and wishing people all the best when they've got appointments and scans and that. But also, if somebody's not feeling well, they can put it on the group, and everybody supports them and hopefully helps them to get through it. So that's a nice additional plus side to it as well, I think.
In regards of counselling, neuroendocrine cancer, they offer counselling. I myself had counselling a few years back through NC UK. I hit a really low point, and it was very much recommended at that point. I was probably about 20 years in at the time where it was suggested that I needed counselling. And I found it really difficult to express my emotions and what I was feeling as I first started talking to the counsellor. And it was through no fault of his own. It was purely me. It's the way that I tend to deal with it. Just get on, get up, get on with it, and don't allow it to interfere with my day-to-day life generally. But it was really, I was finding it really difficult. And without a shadow of a doubt, having the counselling is probably one of the very best things I ever did. He taught me to be kind to myself, and that the bad days are also okay, but to accept them and not be frightened of them. Accept them and let them be, and then tomorrow will be a better day. But the bottom line was, be kind to yourself. You're going through a really bad time. So stop beating up on yourself when you're already being beat up from the inside out, and accept that what you've got is what you've got. And just keep going, basically. So yeah, it was an amazing thing to do. So if anybody is struggling, I would 100% recommend you come and have a bit of counselling, whether it's one-to-one counselling or group therapy. I'm not sure group counselling would have worked for me because it would probably have closed me off, to be honest, until I got comfortable. And I know that Kath and Polly have both done some of the mindfulness courses. So I'm going to pass to Kath about her courses that she's done.
Yeah, so I've done two of the group courses with NC UK. The first one I did was mindfulness for fatigue, pain, and anxiety, which came at a very useful time for me because I do suffer with pain on a daily basis. I do take slow release morphine for that, but it's I needed other ways of coping with the pain because I didn't want to be topping up on drugs all the time. And I found the mindfulness course very useful. I mean, we were in a group and talking about how it makes us feel and how we try and cope with it generally. But this opened up a lot of new techniques, especially this meditation. There's an emphasis on different forms of meditation, which I was surprised actually at how well they worked. And it's stuff that I mean, it's 2 years now since I did that course, and there's things I've just continued using to help me cope. And sometimes it's just a matter of just lying down, closing my eyes, and working through my body from top to bottom to help deal with the pain. And I was really amazed at how well it worked. For Polly, she was she found it challenging at times, but found it really good to speak openly and to be heard and not judged. Having your feelings accepted for what they were, and knowing that your distress signs, which for her were headaches, shutting down, not eating, overwhelmed, irritable, recognizing and acting on this on the mindfulness using breathing and a technique that's called square breathing helped her enormously. And dealing with the emotions that come with it, sadness, loneliness, and anger. There are various self-care strategies that we learned about, and they were very good at reminding us to be kind to ourselves. A bit like when you get on the plane and it says put your oxygen mask on first before helping anybody else. These courses, whether I mean, I've not had individual counselling, but I found the group counselling very useful. And I did the course for living long term with, which is quite different to the mindfulness one. But again, I found it very useful. You're forced to look at yourself in a different way, and it's, you know, it does get quite emotional when you're doing this stuff, and it will bring things to the surface which you might not want to think about, but it's amazing how in a sort of group situation, it helps you to face up to it and deal with it, because you're speaking to other people who are often experiencing the exact same thing. So you know that it's okay to feel that way, and you're not the only person that does. So I found both courses very useful, and if anybody thinks they might like to give them a go, I would definitely recommend them.
Thanks, Kath. So now we're going to move on to some a little bit more practical tips that things that even after 28 years, I'm not going to lie, I didn't know that we could get. So it's actually been an education for me. So I certainly didn't know I could apply for a blue badge. I probably knew I could get a sunflower lanyard. Didn't know I could get some alert cards and other bits. Carolyn explained to us in one of our preview meetings about a Nimbus card, an
Yeah.
Access Nimbus card, which, you know, as a patient living with a long-term illness that has sometimes not very nice urgent requirements to nip to a loo, it gives you, you know, better access to entertainment venues. It allows you to take a carer with you or another person with you as a support. It gets you nearer the toilets. It gets you better seating. It gets you into these places. It even gets you on a train with a carer if you need to, that sort of thing. You do have to pay a small fee to apply for one of these, which is £15. And I'm sure that when the notes go out, we can, if NC UK are happy to, we can share a link as to where to go and get one of these. But I do think that, Kathy, I think you just applied for yours this week and got a positive outcome straight away, didn't you?
Yes, they asked me to send some extra stuff in, which I did, and they've confirmed yesterday that my application had been successful and my card is in the post.
Lovely.
But it's not just entertainment. So I've been having a look today at what you've got access to, and there's lots of things. It's not just live entertainment and theatre as that type of thing as we thought it were. There's lots of places. National Trust, even Alton Towers. There's so many places that recognise this card and will give you help if you need it with regard to getting around places if you've gone out for the day, and depending on what your needs are, if you've got a +1 on there, going into somewhere means that they will get a free pass. You might get a reduced reduction, but it's and there's new things being added to it all the time. I was totally amazed. I didn't know if I'd get it, but yes, I did. So anything like that that comes up is always worth applying for.
And then obviously NC UK have their own set of cards. They've got that urgent toilet access required, carcinoid crisis, risk of bowel obstruction, and insulinoma, which is a tricky word to say at this time of the evening for me, I'm not going to lie. So yeah, obviously the Sunflower Lanyard, you can apply for them through the Sunflower website. And like I say, I'm talking about something I've never tried, I've never done, because as I've just previously said, I just get up and crack on with it and never think about any of the other bits. I know, Kath, you've got your lanyard and stuff, don't you?
Yeah, I mean, I've used the Sunflower for years and they are brilliant. And if you apply for one from I mean, you can pick them up at some of the supermarkets now, because they support the scheme. So if you've got one of them on and you're going to do your shopping, they will ask you if you want some help. Great at the airport. And if you want it, when you apply for a lanyard for a small fee, you can also get a picture card to go on the lanyard, which also has you can decide what needs are on there. So there's little icons that explain what you need. But yeah, you can use them as well in lots of places. In fact, I wouldn't be surprised if that's where the idea for the Nimbus card came from, the access card. But
Yeah.
the Sunflower lanyards, they're especially good for traveling in the UK. You can use them on the train, I say at the airport, doing your shopping, lots of places. So, any of these
Excellent.
things that help make your life easier are worth it.
And
Yeah.
John, I know that you've got your blue badge as well, don't you? So
Yeah, this is a really important fact, really, why it's important to be going along to the nature groups, because I've been going to nature groups for 15 years and I've only just got my blue badge last summer. And technically, no, I'm not disabled, but I have needs. I've got bowel issues. I don't choose to, but sadly, I have to go to the hospital for blood tests, scans. And so if by having a blue badge just helps me, takes a little bit of stress away from parking, eases other things when you want to park and get into places, it just means that you can be nearer the toilet. And I think with what we've got going on with this disease, any help, like Kath just said, you need to take. And I highly recommend, if anybody has neuroendocrine cancer, that they should do their best to get a blue badge, because I was under the impression that I wouldn't get it and I'm not disabled, but actually I do have needs, and I've felt it a lot. It's why do I explain? It makes me feel a lot more relaxed when I go into places like the hospital, whereas I would have been a lot more stressed not being able to park and things. So it is a very, very good tool, really. So if I recommend anything, I would definitely recommend applying for one.
Yeah, it's also
amazing.
useful to note that actually, as we're considered to have an invisible disability, they've got to have a very good reason for refusing you that card, because by law, you're entitled to it. Some of the councils you can apply directly online, and it's a very simple process. whereas other councils, you'll apply for it and they'll ask you for War and Peace. But don't be put off by that. If you think a blue badge will be useful for you, apply for one. I've got one. I don't use it all the time, but it's nice to know I've got it if I need it.
Yeah, I agree. I got mine through Macmillan. They were absolutely fantastic. I'll be honest with you, that's the only thing they have helped me with. So I can't speak highly enough about them. Yeah, they did all the paperwork, and they recommended that I didn't apply. That they helped me apply, and they worded it, and I got it within 2 weeks. Yeah, so Macmillan were fantastic.
Yeah, and because toilet issues is such an important thing for us, that's one of the reasons you would put for your blue badge. But another handy thing to have is what is called a radar key for the disabled toilets. If you notice, a lot of the public disabled toilets have got a lock on them, but majority of them use a standard key, which is called a radar key. And you can actually buy these online, Amazon, eBay, lots of places. And I would recommend you buy a multi-pack. For me, I always make sure I've got one in most of the handbags that I use if I'm changing over. And I also keep one in my car as well, just in case. They're a really useful thing to have, and it does make life a lot easier.
Yeah.
Good tip there, Kath. And obviously, we all, a lot of us have our SSAs, don't we? Our monthly injections. And it's key that your healthcare professional that's doing those knows how to do it properly, stretch the skin, not pucker it. If it hurts, use EMLA, the gel, to numb the area. And just make sure it's out of the fridge a few minutes, 40 minutes before minimum, so that it doesn't hurt when it goes in. Administer it properly. And, just watch your sites. Don't get sore and painful. I don't have them currently. I have done in the past, and when I did, I used to do it myself in my thighs. John, you do yours yourself, don't you?
Yeah, I
Kath
did.
does hers.
Yeah, I just felt going to the hospital was I had to go in the early days because that was the only way to get a lanreotide injection. And then many years ago, then they trained you and they changed the syringe type so you could do it yourself. And it just, for me, it just took the stress of another hospital appointment, sat waiting, dwelling, and it just meant I felt a little bit more in control of my life. I could do it at the time of day I wanted to do it. I always used to do mine late at night before I was going to bed. And I didn't then stress about it because I could choose when I wanted to do it. But most importantly, I was in control of the pain. And yes, it does hurt. Let's not talk about the needle size, but it's more to do with learning how to administer it to yourself, because we're all built differently. We all got different pain thresholds. And after, half a dozen times or so, you sort of get to know the best place. And it is a lot less painful, I believe, personally, doing it yourself in the right position rather than waiting for somebody just to jab it in. But I had some quite bad experiences with nurses, not particularly well administrating it. And so for me, I think it's a good thing, but not everybody wants to do it. So it is something to be considered.
My husband does mine for me. So if you don't want to do it yourself, but you want to have the control, you can see if your partner or someone is willing to do it for you. And again, same as like with John, it just gives you so much control. And an example for me was when I first started, I used to feel quite bad afterwards, and my injection day had somehow fallen on a Friday. Which wiped out the weekend. But once I took control of it, I was able to gradually move this along, and now I have it at the beginning of the week. So if I'm going to be ill, it doesn't ruin my weekends. And it's little things like that can make a big difference to your own quality of life.
Yeah, definitely.
Moving along a little bit to personal and things to make sure that you get done is formally add your loved one as a carer to help healthcare professionals communication and allow them to be your advocate as and when you needed it. There are no other words needed for that, I don't think. Make sure that your healthcare professionals know that if you're there with your partner, your carer, even a friend, your children, anybody who may want or need, and you're happy to talk on your behalf in an appointment, or if you're taken poorly suddenly and you need them to be able to advocate and talk on your behalf if you need to get help urgently. It needs to be on your records and noted that you've approved that to allow them to talk on your behalf. But also it is your right to not have them advocate and talk on your behalf and take over. It's your illness at the end of the day. I certainly had some friends at one point who used to come to appointments and try and tell me how and what I should be doing for my illness and take control. They were trying to take control of it. And at the end, they were trying to do the very best, but at the time it was too much for me, and I found it overwhelming that they weren't accepting. It's my illness, let me have it my way, sort of thing. And NC UK, from the handbook in section 9, there are downloads of frequently asked questions about me, holistic needs assessments, forms to complete and share with healthcare appointments. Fill these out as and when you get a symptom is a great idea, because you can then take them to your appointments with you, and you've got the records and the backdated information ready to hand to them at the appointment, so you're prepared. I don't think, Kath, Jon, there's much else to cover on any of that.
Don't think so.
No, I think so.
No. So we're going to move on now to a discussion on some things that I think we've probably all found difficult at some points, making sense of some terminology and the impact that these words and others can have. And not only what the words are said, but how they're said sometimes has a big impact on you as a person. So obviously, the vital difference between incurable and terminal. I'm incurable, but I'm not terminal. And the key difference is that if you are terminal, you are generally given about 6 to 12 months to live, but you can live long term with incurable. And stable or indeterminate, I'm going to pull in Kate or Nikki to help me out on that one.
Okay, so stable, many of you will have heard, and some of you will love that word because it means there's been very little change. But stable from a medical point of view, when they're looking at your scans, means that there may be some slight changes. But so, for example, if you have a 1 centimetre nodule or tumour, if the next time you go, it's 11 millimeters, so 1.1 centimetre, that would still be called stable, because the difference between 1 and 1.1 is less than 20%. So it's only 10% change. So in terms of growth, something has to grow more than 20% of its original size. In terms of response, it has to have shrunk by 20% or more. There is some slight flexibility on that, but in general, if it falls within 20% above or below its original or its previous size, then that would be called stable. Now, indeterminate is different. Indeterminate is when they're looking at something on the scans, and there's certain criteria they use when they're interpreting scans to be able to define what they're looking at. An indeterminate, it may refer to something that may be less than a centimetre and not fully show the characteristics for them to actually be certain what they're looking at. So if you see indeterminate on something, it means they've spotted a slight change, but the change is not significant enough to be defined as one thing or another. So, for example, if they may note a lymph node or two may look slightly different. Now, our lymph nodes can be enlarged if we've had a recent infection, a bit of a flu, cold, anything like that. So it could be reactionary. So the change may not be necessarily because the lymph nodes are involved. And so they will mark things that aren't definite as indeterminate. And when you have your next scan, or if anything else changes, then they will relook at it and compare it to be able to see if that's changed. So often reactionary lymph nodes, say if you've had a recent infection or a recent vaccination or anything, we're in the flu season after all, it would be if it's reactionary or inflammatory, anybody with arthritis, etc., or any autoimmune disease may have fluctuating sort of inflammatory responses in their lymph nodes. You know, it usually resolves. It doesn't usually progress to a definite change. So indeterminate means that it's not right, but it's not right enough to define, if that makes sense.
No, perfect. Thanks, Nikki. Is it a cure or simply no visible disease? Well, that's a tricky question, isn't it? I have no visible disease, but I'm not cured again. And I've had no visible disease for many years. So I'll never be cured, is what I've been told. Although in the beginning I was told when they took my primary out that was me cured. And yet, less than 5 years later, it had come back. So I think now, my understanding is that generally you wouldn't be told that you were cured for neuroendocrine cancer. You would be declared as no evidence or no visible disease, is the term that they would probably use now.
I just mention because there are very few neuroendocrine tumours in which they may be able to say cure. And for
Okay.
example, that could be, say, an appendiceal net where you may have had no signs of neuroendocrine beforehand. It's a post-op diagnosis and it may be just a few cells at the tip of the appendix. But because they've removed the whole appendix, then they've removed it all and the chances of it recurring are zero. Unless there's any signs that lymph nodes or the bowel have been affected. Similarly, a solitary rectal polyp or a solitary incidental gastric polyp, if completely removed, that may be cure. You may have some follow-up short term, but there are a few really tiny, isolated, odd little things that may show up that, if completely removed, may be regarded as cure. And because we don't know why neuroendocrine cancer occurs in the first place, we can't tell you what to avoid. So, because they grow differently to other cancers, the time to recurrence, if it's going to happen, is different than in other cancers. And so that's why we are very cautious and often say no visible disease rather than cure.
Thanks, Nikki. Moving on to palliative care, and I am going to pass this on to Kath because she is under a palliative care nurse and can explain more on that for us.
Yeah, palliative care, it's one of them good old stereotypes. A lot of people get scared when they hear that word because they think it means end of life, but it isn't. Palliative care is really about helping to give you a better quality of life. It's about giving you the best care so as you can function in everyday life. I have a pain nurse that looks after my pain medication. As I said earlier, I've been on slow release morphine for 6 years. I was referred to a pain nurse by the Christie, so as whenever I had a problem with pain, I could speak to the nurse specifically about this and it would be sorted as quickly as possible. And the nurse does help me to manage this. And it has massively improved my quality of life. A good example is that I've just had my medication upped due to a change in the pain. And because it had been such a long time since the last change, the nurses had referred me back to my GP. But when I rang, they said, if you have any problems with speaking to your GP, just come straight back to us and we will sort it out. And knowing that you've got that backup there for this type of palliative care, it makes a massive difference. So don't be scared of the word. It's there to make, palliative care is there to make our lives better. Definitely.
Thanks, Kath. That probably takes out the stigma of it to a lot of people because, like you say, it is very generally associated with end of life, isn't it?
Yeah. I mean, they even rang me today just to make sure that everything was okay with the change and that things had settled down again.
Excellent. So recurrence or progression and dealing with the news that isn't what you'd hoped for. I'm a bit of a unusual case because I don't tend to get progression because they take it all out. Every time I get a recurrence, they just knock it out again, take it all out, surgery, off we go. I know that Polly has sent some notes on progression with regarding her husband Mike, that he's now got heart mets, and that's really difficult to get her head round. And she had a great chat with CNS, and that's helped her. And then she's been to Maggie's, and do they have a plan? You've just got to trust your team, she says. It's really difficult, and he's on chemo currently, and they hope that it will do what it needs to do. Kath, you've had progression. Jon, you've probably had progression as well. So yeah, feel free.
I've been stable. I've been very stable for a long
Lucky.
time. Yeah, I am very lucky. So I've not got a lot of experience on this one. Sorry.
Yeah. So I had progression 6 months after I was diagnosed, which got me referred to Chrissie in Manchester, which is a centre of excellence. And then everything was stable for about 3 years, and then I had a progression again in 2018, which is when I had the PRRT. The thing for me is I feel like my disease is a bit of a time bomb because I'm classed as inoperable because of where my primary is sited. It's I think I said last time it's not safe to go in unless they've absolutely no choice. So it's progression is the one thing that I fear. And even though when I have a consult, it doesn't make me too anxious about it because, you know, if something has changed, we've just got to deal with it. But the anxiety does get a bit much sometimes because it's something you have to live with on a 6 monthly basis. But for me, it's because my options are for treatment are limited. But unfortunately, it's for a lot of us, it's just a fact of life. But that then brings me back to the counselling, which is also the group counselling has helped me deal with that and given me the tools to deal with it when things get too much.
Yeah, and I think
often, but you know, it does sometimes get on top of you, which is normal.
it absolutely is normally, and I think Kath, you have the fear of progression and the anxiety of that. And I probably have the fear and anxiety every few months when I go for follow-up scans. That is this the scan that's going to say, yeah, Chrissie, it's back and it's here, and this is where we're at with it this time. And that, you know, maybe one time they'll say we can't operate and take it out again. And then my whole journey will change drastically. And we'll go to questions from the group.